1. Sir, we are live now.
Thank you.
Sir, yes, Jones. Yeah.
Yeah. So good evening, everybody. Welcome again to today's webinar brought to you from the Orthopaedic Research and Education Foundation. And today we have the pleasure of having Professor Rajagopalan, who I know from a long time, in fact, from my medical college days in Pondicherry in JIPMER. He has since been to many places, including being professor at St. John's Medical College in Bangalore, and now is back in Pondicherry in the MGMC and RI. So it's the MGM Medical College and Research Institute, where he is now an emeritus professor. So I think he's going to talk to us today on ankylosing spondylosis, again, an area which is important for DNB students and PGs alike. And so therefore, I would request Professor Rajagopalan to go ahead. In the meanwhile, can you, Janki, can you mute anyone who's not supposed to be speaking?
Yes, sir. Yes, sir. Yeah.
Okay. Over to you, Rajagopalan.
Thank you, John. Respected Dr. John Mukhopadhaya, Dr. Janki, and all the audience. Good evening to you all. First of all, I thank Dr. John and the team for allowing me to share my thoughts with you. And now to my dear students, I have chosen this topic. Of course, it is an important topic, even from not only from the exam, even otherwise. But that's another reason is that an ankylosing spondylitis coming to you whenever you practice, wherever you practice, at a stage where when the patient walks in, you can diagnose, but that will be of very little help to the patient. Quite a few patients we miss out because we do not think of it in an earlier stage. So, and that's why one of the reason this topic I wanted to talk to you on, and not a very good topic. A trauma is an easier topic to keep you awake, but this is difficult. I hope you benefit. With that, I beg you greetings from Pondicherry. I will be talking to you because sometimes the question paper for you is what are spondyloarthritic diseases or what are seronegative arthritis, write about any one of them, questions like that. So just a few words on that, then we'll be talking on the different aspects of ankylosing spondylitis. But look at the third one on the list. I was trying to tell you what, if you see in a OPD setting, what will make you suspect an ankylosing spondylitis before it becomes obvious even to the blind man. So let's go. So this seronegative arthritis or a spondyloarthritis, this is a group of conditions which have a similar etiology, similar features. They have a common clinical features and a common genetical features. And ankylosing spondylitis is the prototype, the thing which you always comes to your mind when you talk about spondyloarthropathy. There, I am not going to the list of all those things because that's beyond what time won't left me, but things like reactive arthritis, psoriatic arthritis, we always think of that whenever you have a polyarthritis, or the one associated with the inflammatory bowel disease. This undifferentiated spondyloarthropathy came last. All these things list continues. But if you see this picture, the red one which you see is probably the biggest member of this family. Forget about USPA, we'll not talk about it today. It's the biggest this thing. So that's probably why it is very important for us. But none of this, all these things are things which are not something which you will not see. But what is common to all of them? If you think of the 5 major points, which is a common feature. In other words, if you get any member of this for a short note, these 5 features will apply. First, by definition, they are all spondylo, they are also seronegative arthritis. So they are seronegative. Then you have a common genetic factor, which is HLA-B27G. We'll come to that later. Then they all have an axial involvement. Axial means involving the axial part of the body, spine, that area, not the peripheral part. It is seen in all of them, whichever be the member, they all have axial involvement, and that is essential for diagnosis of even ankylosing spondylitis. Enthesitis, what is that? We'll come to that in another few slides. Or the inflammatory changes seen where there is attachment of tendon or a ligament to the bone is the primary pathological phenomenon. This is a whole difference between this and rheumatoid. And they have many extraarticular features, which also right from the ocular to the skin. So that is a spondyloarthritis. And ankylosing spondylitis is probably the most common and the most important group of that. And so ankylosing spondylitis has got other names. Sometimes nowadays you don't have it. In our days, these eponyms are popular. You won't ask you ankylosing spondylitis, they will put it as Meredith Trumbull disease. In fact, I had that as a short note. So there is other names, and I'm not going into the thing. But it's an autoimmune disease. The basic feature by this thing is that it involves spine, involves circular joints, and adjacent tissues such as tendons and ligaments. Remember, it can be just involving tendons and ligaments also, with a minor involvement of the axial structures. Some peripheral joints can be involved, and there could be extraarticular manifestation. That is what we will be discussing. The most important thing is it affects young adults more in the male, and they have a strong genetic features. Now, the outcome. What is one thing is good about ankylosing spondylitis, even though it has got so much deformity, etc. Generally, the outcome is better than, say, compared to a rheumatoid, which is totally different. But if you compare to that, this results are generally better. Now, the most important thing is it is still not clear why it's coming, what is it to do? Is it only from genetic ones? Is there other factors? Not very clear. We have a lot of knowledge now compared to what when we studied. But today it is still, there are many theories and studies going on. And in one field, they even now something is being added. But if I should take 5 at least out of all the thing that is in which the last one is not a very old one. Vitamin D, this meta-analysis is one of the comparatively recently described one. Probably it is multifactorial. All of them have a say. I myself don't know. But initially it was thought to be more genetic because they found the HLA-B27 in it. That was talked about. Then immune reactions came. Then there was saying that the HLA stimulates the microbial infection. Then they were talking about endocrine abnormalities, and they even up to vitamin D. But answer is we do not know. But one thing is HLA-B27 is positive in roughly 20 to 25% of these patients. But is that the most imperative factor? We really do not know. What is the precise role? We do not know. There is theories, but we do not know that exactly how. But one thing is sure, I'll come to that again later. HLA-B27, we could have talked the whole day for it. It is a lot of work is going on. It doesn't mean, it is not a lab test to confirm the diagnosis. It may be good for screening somebody. It may be good to study the basic knowledge to know how it works. But it is not, HLA being positive or negative is not going to be important for diagnosis. But how it influences, we'll see. I'm not going to spend much time on that because being 7 p.m., you may feel sleepy. So I'm not going to that. And most important, we don't know the precise role. But they are thinking that it may resemble or act as a receptor. That receptor may incite an antigen. That may be like a bacteria or bacterial-induced products. This is one possibility. Then they are thinking that there are several other genes which are associated, which along with their involvement can lead to development of ankylosing spondylitis. This alone can go for another 10 slides, but some of the genes which are associated are ANKH and HLA-B, HLA, DRB1. DRB1 and the numbers are going. So this is just for you to understand only one thing. HLA is positive only in 25% of the patients. Number 2, HLA exactly how it works, we do not know. It's not a lab test for diagnosis. It is not a lab test for diagnosis. Susceptibility for screening, it may be good. That's all you have to know. I'm not going to more than that. But look at this. In a healthy white population, 8% only is positive. But those who are having ankylosing spondylitis in the whites, 92% HLA positive. But the Africans who are with the 4% without healthy people, it got only 50%. So there is some tendency, something to do with HLA, but it is Some probably we can say inducer, something like that. But even in psoriasis, psoriatic arthropathy also it is positive. So that is going to be positive in all this. Now, why this problem? Because the pathogenesis is probably very complex. There may be a variety of complicated mechanisms resulting in the disease. There are many hypotheses to how this happens, but that will be beyond the scope of this talk. And what looks very attractive, or at least to me, is the role of the immune mechanism with some kind of gene interaction. I read about it, but I can tell you, I'm quite sorry, most of it goes above my head, but I'll just show you one or two pictures. For you that if you are interested, you can read later. This endoplasmic reticulum aminopeptidase 1 and 2, ERAP 1 and 2, such a long name, so I'm going to use an abbreviation name, is considered now an important pathogenesis of AS1. I just go to a picture and come back. So if you see this picture, this is an immune mechanism. This is the HLA-B, how it comes. This probably everything has a role. You look at this picture, how many factors are involved? Right from TGF to TNF alpha, that is tumor necrosis factor alpha, interleukin 17, and RANKL, everything, interleukin 1 beta. Interleukin 17 is 1, and 23, I don't know where it is in the picture, 22, 23 is here, and 23 is here. This 17 is 1, which has been in the limelight of probably 3 to 4 years. You might be hearing about some of these disease modifying agents, immunomodulator drugs. One for interleukin 17 was FDA approved in the 2019. So this is coming into a lot of, let me say, in the studies, it is one which is a lot talked about. So many factors and many genes are probably involved. And now the research is more on interleukin 23 and interleukin 17 axis. And these probably have something to do with the lymphocyte activation and leading to the diseases. Now, most immune cells and cytokines participate in the pathogenesis of AS. You saw the picture, so many. But 23 and 17 have a role. And now what they are thinking that it is mainly involving immune T cells and B cells also involved. Why talk about all this? Because you come into the market, you will find a interleukin 17 inhibitor, you will find another TNF alpha 1 inhibitor. Both these drugs are true, both act in a different mechanism, but all of them act in only one mechanism. It may not be helpful for the patient who has got a mechanism through some other area. So just an example, these are the interleukin 17s here, the yellow ones. This is the inflammation. This is the IFN7. All these go into that. So the interleukin 17, that acts with either TNF alpha or the IFN, and that interaction leads to one. So you need both to produce the development of ankylosing spondylitis. So it is a multifactorial, multiple level disease. That is why you see a different spectrum. This is what I think. Let's go to the next one now. When we come to the etiology or pathogenesis, we were talking about ankylosing spondylitis, but if you take enthesitis, I repeat again, wherever tendon joins a bone, for example, tendo-Achilles, joins the tuberosity of calcaneum below the upper 1/3, the upper 1/3 and the middle 1/3, lower 1/3, the tuberosity, you got that area. Or even where a ligament joins the anterior body of the spine, wherever a ligament or a tendon joins the bone, inflammation in that area is called inflammation. How does that work? This is a normal vertebral body. You have to see the corner. That is where your longitudinal ligaments are attached. So the ligament to the bone, the TNF alpha, tumor necrosis factor, or where there is an erosion, it could be cathepsin K, metalloprotease mediated, or it could be a BNP or a WND pathway. So all this forming the syndesmophyte, which causes your bamboo spine later. So all these mechanisms, this was an article, from the Rheumatoid Journal of Rheumatology, and it was showing the pathogenesis of ankylosing spondylitis. But to put in simple words, enthesitis, both in the axial and upper skeleton. Axial skeleton, we are talking about spine. Upper skeleton, let's say calcaneal tuberosity, is the primary pathological feature of spondyloarthritis. Why do you say primary? You can have an ankylosing spondylitis presenting only with enthesitis. Your spine may not be involved. You are just going to treat it as a calcaneal spur and forgetting about it. Then you are missing the early stage. Whenever you say enthesitis, you will have to think of this, and there are the ways to find out. So enthesis, where the ligaments are touched, already I told you. And what happens initially, there is inflammation which will cause a edema, then there will be erosion, then there will be ossification, finally there will be ankylosis. So this erosion leading to ossification, ankylosis will happen in a joint. Ankylosis can happen in the spine, where a heel, for example, where the tendon is inserted into the tuberosity, there it will be a spur. The circular joints, which are the one in our postgraduate days when we join, ankylosing spondylitis means circular joint. Even today, yes, but we'll come to the difference later. So the circular joint, same way. There also you can have the same steps going through. Now, what about the spine? Spine, if you look at the junction of the annulus fibrosus with the disc cartilage, that is the anterior major vertebral body, there, as I told you, you can have a enthesitis, you can have a syndesmophytes, and they all can bridge with each other, causing what is called a bamboo spine. The facet joints exhibit synovitis. The ankylosing spondylitis in a peripheral joint or an axial joint like facet, it can cause synovitis. You can have synovitis and enthesitis. So in the spine, you look at this, you have a facet joint, which is a true joint. What's a true joint? A true joint was the one which is a synovial joint. The only true joint in the spine is a facet joint. That can exhibit synovitis, whereas the anterior vertebral body with the anterior longitudinal ligament will show synovitis. Sorry, will show enthesitis. So the same disease acts in a different way, obviously through different mechanism. That is why you have so many pathways. So let's come to the spine and circular joint. They are the most common in joint involved, most prominent involved, and they are typical of seronegative arthritis. Low backache is a symptom in 75% of the patient. So that is what I'm telling. So you have a young patient with a low back pain. You don't have to think of only the disc, etc. You may not be able to take that stage. It takes minimum 3 months before you label a patient as an ankylosing spondylitis. But you can think from day one. And some patients present with the pain in the gluteal region. It is very classically alternate. For some time, it will be in the right gluteal region or right buttocks. Then afterwards, on the left buttock, it may just migrate and from right to left. This alternating buttocks gluteal pain is one of the important features of ankylosing spondylitis. Where you see them, you can really you should think in your mind, can this a beginning of a ankylosing spondylitis? Already is having one. After this only, after the back pain, after the gluteal pain, then only patient comes with a limitation of movement. Quite often, that is what when you are going to look for your Schauber's test and you are going to look for your what do you call the amount of forward bending showing limitation of flexion. They are late symptoms. This is what I want to tell you. So how do you diagnose it? What do you think for the thing? First of all, a patient, a male, females are not uncommon. I have seen quite a few, but the males are much more common. A male before the age of 40, a young man, insidious onset, slow onset. The usual time is about more than 3 months. Doesn't mean that one day it is going to start, but before you label, it has to have a minimum period. If you take 3 to 6 weeks for rheumatoid, here it is about 3 months. Morning stiffness is also a feature, but usually longer than 30 minutes, not necessarily 1 hour like your rheumatoid. The classical feature of an inflammatory problem is the pain is improved with exercise. That is the one which should make you suspect. That patient feels better after movement, after exercise, and the night sleep is disturbed, not like the night case of tuberculosis, which is common in the first half, not like the chronic malignant pain of a malignancy in the night, which is throughout the night. This is second half. So you have a young man with a back pain more than 3 months. He has got pain is better with exercise or activities, and pain is disturbed in the second half of the night. And then comes the last one. If you have an alternating gluteal pain or a buttock pain, you can probably clinically label him as ankylosing spondylitis. So when you examine, what do you look for? I think all of you know this. I will go a lot explain. You look for tenderness. You look for decreased range of movement, or the movement, whatever, according to cervical, lumbar, etc. Chest expansion, that you will all not forget, I'm sure. There may be a kyphosis. If it is there, then already you are late. Deformity has set in, and there could be a costochondral tenderness. I will come there because that is also a feature of your enthesitis. Schauber's test, I think you should know. If you do not know, I am not the forum to tell you that. Schauber's test, which is very diagnostic, indicates limited movement, and by that time, I think it has been late diagnosis for the patient. You must test a circular joint in all these patients. Chest expansion, Schauber's, circular joint, and look for the common sites of the enthesitis. I already told you, costochondral, Achilles, and peripheral joints. It is more common involving the lower extremity joints, asymmetrical, unlike the symmetrical involvement of rheumatoid, asymmetrical. And hip is common and more of the lower limb, unlike a rheumatoid, more common in the upper limb. That is symmetrical, this is asymmetrical. And now coming to the symptoms of enthesopathy. First of all, the enthesopathy can be central and also peripheral. Peripheral, I already told you. Central also I told you. Anterior vertebral body, anterior longitudinal ligament vertebral body, or a syndesmophyte, and peripheral of calcaneal spur or any other parts of the body. So what are the important axial one? Peripheral, spinal is axial, costovertebral. We always talk about costochondral. Costochondral is important. There is a costovertebral joints, but the enthesitis can be costovertebral, mandibulosternal, sternal clavicular, costochondral, and even in the clavicular joints. So all this can have it. The costovertebral enthesitis leads to, or the involvement of the costovertebral movement causes the decreased chest expansion. Even fingers are known. Sausage fingers are classical of psoriatic arthritis, but you can have a dactylitis where there are ligaments inserted into the phalanges. That is a extraspinal peripheral enthesitis, Achilles tendinitis, and plantar fasciitis. Because plantar fasciitis is very common, but that could be a feature of that. So inflammatory, next comes to joints. I told you about enthesitis, but I told you about the involvement of joints. Now we come to the inflammatory arthritis. We told about the facet joint arthritis there. The inflammatory arthritis can be axial, like facet joint, appendicular, hip and shoulder. Hip is by far the commonest. Shoulder probably. Hip and knee are the commonest. More common in the lower limbs, asymmetrical, and they have as I told you, common in lower extremity. The general extra-articular manifestations or general manifestations, I think we would have known all this. We often talk about conjunctivitis, which is a part of reactive arthritis, iritis. You can have valvular heart disease. I think in the MBBS itself, we learned that aortic incompetence, 4% of cases of ankylosing spondylitis, and there could be even conduction distribution. But ankylosing spondylitis can also be cause a restricted lung disease, because chest expansion is restricted because of the enthesitis and costovertebral joint involvement, and this can have a restricted lung disease. Colitis known to be C1, C2 subluxation is a common feature of rheumatoid. It's not a common, but the uncommon feature of ankylosing spondylitis, but it can occur. Now, what will you look for? You will invariably, the first thing we look for, Among the other important thing that we look for is the limitation of movement, ask the patient to see how much is the spinal flexion, lateral flexion, etc. Then we look for the kyphosis. You can see the in the picture. You can see the picture. You can see the. Unfortunately, in my view, it is covered by our screen with all the names. So you can see the upper thoracic area. There's a kyphosis, but it should be possible for us to think of it early and prevent them rather than treat them. This is about the clinical diagnosis. What I was telling you was not from theory point of view, but what you will see, look for it when you see a young male with a back problem. Now, when we mean diagnosis, we are talking about the scoring system. I'm interestingly avoiding that much because you all can read it in the book. The most common scoring system is the modified New York criteria, but really speaking, it is 1984. It has not been validated. There are much better ones, but I'm not going to talk about it. But what you need, if you are going to still the examiners look for this criteria, I'll come to that in the next slide. But all these are made up of so many things: symptoms, examination findings, and imaging. For example, if you are going to, I think we will come to the next slide. One of the thing is that if you are going to diagnose it with a plain radiograph, and that is not really early. Like, look at this. Now, what is the classification system? I'll go to the classification system, then come back. So if you take this modified New York criteria, then you have clinical criteria, radiological criteria, grading criteria. Now, what he says is that you should have at least one clinical criterion and a radiological diagnosis. So that means if you don't have a radiological diagnosis, you will miss it. Radiological diagnosis, suppose, let me say you are looking for sacroiliac. That may take years to come. So you might miss them. That is one disadvantage, but all that also done. It is one of the most standard classification. So you are described in the year 1984. I have given the reference there, but it's a good one. That way we see mostly the late cases. It should be fine. This is available in all the books, so I am not going to read it or spend more time. There are other classifications which I am not even discussing. Even after whatever I have put, another two more I have put. One is it is called Spondyloarthropathy Study Group. All that I have a European study group. But I am going to this. This is not a criteria. This is for you to think of, practically think of an inflammatory back pain. You have a patient, a male patient with a back pain, and if you think it is an inflammatory, there is a chance. So let's look at this. One, the morning stiffness. All of this is history. Morning stiffness more than 30 minutes, improvement of back pain with exercise, but not rest, and nocturnal back pain during second half of the period, alternating buttock pain. You take these four features. If two are positive, then it has got a sensitivity of 70% and specificity of 81%. It is more specific than even sensitive. That means in an OPD setting, this is the one which you can use just to know. You may see 20 OPD patients have backache, or you can't, everyone you can investigate, you cannot this thing. At least you can, this is a rapidly usable one. Why is it not moving? I don't know why it's not moving. Okay. So now you have seen the patient, you have looked at the thing, how do you investigate? The first thing everybody will say, HLA-B27, it is not a diagnostic test. It is only, it is going to, okay, it may be added factor, but it is mostly for screening purposes. You do a routine ESR, CRP, they may be elevated, may not be elevated. It depends. It really doesn't correspond to activity of the disease. Some show high, some do not show high. What is the role is a X-ray. Unfortunately, I'll come to other investigations. The first thing that available is a plain X-ray, and this particular plain X-ray, if it already shows you changes in circular joint, then you don't have a problem. You have a one radiological finding, then clinical finding, you can use the 84 criteria. So this is essential. A sacroiliac is essential for the thing. And the sacroiliatus, peripheral joints are not symmetrical, but the axial joint, sacroiliatus is symmetrical. These radiological findings of sacroiliatus are classically symmetrical, and they are radiographically graded into 1 to 4. There are other classifications also. I am not going to that. The grade 1 is suspicious whether it's involved or not. Grade 2 is minimal. Grade 2 is moderate, and grade 4 is ankylosis. In this, I think the ankylosis, there can be no doubt. But the other three can vary from person to person, highly subjective. But okay, it is still very simple. So if you have a imaging, sacroiliatus shows a change, then okay. Now if you look at just an example, a classical one, which you will say an calcaneal spur, not necessary. It could be also a beginning of an enthesitis. But what is more important, you say sacroiliac joints. This is a bilateral one. You can see here that this, of course, there is where the joint space you are seeing compared to this on the right side, there is definite changes. So this may be suspicious, but here there is no doubt. Here it is ankylosed already completely fused. This is somewhere between the moderate. This is already ankylosed. So once you see that, once you get used to it, the sacroiliatus probably. And if you see an X-ray like this, where one of the features, one of the early radiological features commonly asked in the MCQ those days was squaring of the vertebra. What is that? The anterior body of the lumbar spines always is slightly convex. It is not a strict right angle, a straight line, slightly convex. This is a straight line. This is called squaring. What is convex becomes a straight one, that is called squaring of the vertebra. That is because of the ossification of the anterior longitudinal ligament. Then look at the facet joints. Facet joints, what you may find? You may find erosion, you may find even fusion of these joints, but calcification of the ligaments. For example, this is the interspinous ligament. These interspinous ligaments may become calcified. So let's look at this sacroiliatus. Here there are bilateral sacroiliatus and there are some erosions. We can see this erosion there, erosion here, and both in the sacral side and the iliac side, and there could be subchondral sclerosis. Now, all this is fine, and this is one where there is no doubt. You can see the entire is completely fused. There is no doubt. That is the last stage of the one. And vertebral body, you have developing a bamboo spine, a complete vertebral body. You can see the anterior syndesmophyte joined together, fusing together. This will become a bamboo spine in no time. And that is your AP view. You can see the big syndesmophyte joining here, and that will be a complete fusion of the anterior thing. And if you take the lumbar spine, you will see the bamboo spine. So these are the ones which are the last stages. There's no cure for the disease at any stage. So these are the ones where nothing more can be done. We can only do something to improve some difficulties for the patient. But these are the ones which should not be for diagnosis. And it's a rare thing. We have a calcification vertebral disc. It happens in conditions like onchronosis, etc. But another condition where you can have a calcification is the ankylosing spondylitis. And this is shoulder joint and acromioclavicular, shoulder joint here, acromioclavicular joint here. This is the clavicle and this is the coracoclavicular ligament. And the coracoclavicular ligament, you can see there is enthesitis here, there's a spur formation here, there's a spur formation here. So there can be irregular bony proliferation of the ligaments. Hip joint, what do you find? There could be involvement of joint. For example, you can see the narrowing here, but also sometimes you will find an extra-articular fusion because where the ligaments are attached, there can be a newborn formation, and they have happened in this particular patient. Sacral joint is completely fused, but you can make out the narrowing of the joint space, and hip joint is the most common involved. Now, these were plain X-rays. What is the disadvantage of plain X-rays? It may take years to show a sacral joint change. You are going to wait for that and then call it ankylosing spondylitis. it is going to be sad for the patient. If you do a CT scan, you can make out the erosion. These are the erosions. Very nicely you can make out. But even this is not as good as this one. So what happened? Before I go to the next one, which is MRI, we have to understand that still the gold standard is, from your exam point of view, gold standard is a sacroiliitis, which is diagnosed by the plain X-ray, is still the gold standard for diagnosis, no doubt on that. But the finding of sacroiliitis on plain X-ray can lag behind the symptoms. What can you do? If you do a CT scan, you can see them early. But the best is going to be MRI. It can't be affordable for everybody. You can not use it for screening, but we should know. MRI has got the highest sensitivity and specificity for diagnosing a sacral joint inflammation, much before it damages the joint for you in the X-ray, much before. So if you do a MRI of the sacral joints and the pelvis, we can do a fat separate image or a gadolinium contrast. You can see the inflammatory features. What will be seen? I don't have a good picture. I have taken a book from the book because I couldn't get any MRI for that. And also you can see the MRI. MRI is good for edema, good for soft tissue. A synovitis, one of the best thing to see early. Any edema for that matter, MRI. So that you can see. You can also assess the spinal inflammation. But you see this, I am not going to this pictures from the book. You can see the MRI here. Oh, unfortunately, I don't know where you can see. It is hidden. I don't know where. I tried to remove this from here. Yeah, I could remove it. Okay. Now, this is the sacral joint here. You can see this white. Anything hyperintense in the T2 weighted image is a edema or a fluid. You can see the edema on both sides here. This is dark. There's no edema here. This is an early sacroiliitis. This is the stage. If you can detect that, then we have a proof. It doesn't fit into the 84 criteria, but it's an imaging proof. And if other symptoms correlate, symptoms will be there. You can diagnose them early. I won't go into spend time in that. So next is the treatment. About the treatment. Unfortunately, as of best of my knowledge, there is no known treatment which can cure an ankylosing spondylitis. So what we can hope is to, I don't know how, I just put this down. Yeah. What we can do is we can try to reduce the pain, reduce the loss of movement, slow the progression of disease, but the most important, prevent the deformity. Tell the patient, teach the patient, make him maintain the posture and preserve the function. This can be done with the help of physical therapy, exercise, and medication, which are, so these form the most important. The surgical treatments have no opportunity at this time. This is the different, this is by the Euler recommended pharmacological treatment. I will go to it later if we have time, but let's see what do we have in terms of pharmacological thing. The aim is to improve the spinal flexibility and maintain the flexibility, posture, relieve symptoms, functional limitation, reduce the complication, what I told you earlier. And the mainstay is a non-steroidal anti-inflammatory drug and TNF-alpha inhibitors. The list is keeping on increasing every year. So I may not be able to tell you at least till about 2-3 years back what has been approved. Now, the other than this, what are the came is the non-TNF1 biologics like secukinumab, methotrexate, and sulfasalazine. There are also JO inhibitors, this tofacitinib. I think all of you will be familiar. It is being promoted quite actively in our country. It's good. Since I think about 3 years, I think, and by the pharmaceutical industry, it's a molecule. So many have come out even in the last 1 year. And filgotinib, these are both approved by FDA. And it's so difficult to pronunciate this one. Ixekizumab. This has been approved by FDA in 2019, came into the market in 2020. There it is a interleukin IL-17A inhibitor, interleukin 17 inhibitor, and it is also for ankylosing spondylitis, psoriatic arthritis, etc. So all these drugs are good. They are not, good in the sense they can block that particular thing. What is interleukin 17? targeting the interleukin 17 pathway, if that can stop that, then patient will not develop those symptoms. That's how it acts. That's the very simple way of putting it. So they definitely have a role. And anti-inflammatory drugs should be prescribed. The first thing which I follow is only NSAID for the first 3 months. Then only I go off everything else. They reduce the pain. Because they reduce the pain, function is not affected much, and you need the maximum. If you go to the algorithm which I show you before, I'll go to that later. They advise to put 2 NSAIDs. I don't do that because the amount of kidney damage will be very high. So let me say if I'm using diclofenac, I use 90 milligram. If I'm using etoricoxib, I use 120 milligram. And that needs for efficacy. If it gives effect, well and good. But if that doesn't work for 3 months, then you go for the other disease modifying drugs. The NSAIDs, where they can modify the disease, that is really not clear. Role of steroids, I personally believe there is not really speaking, there is no role for systemic one, maybe a limited role, but a enthesitis, whether it is a peripheral or even anywhere, you can be used. Steroids can be long-acting steroids can be given to circular joints. There are some studies showing that it is beneficial. But this is all I am talking about. Now I'll just go back to this fast to this. This is I don't want you to go into details. I don't want you to read. But once you have made a clinical diagnosis, physiotherapy and education, simple thing: stop smoking. It is must for all patients of ankylosing spondylitis. Has been proved that makes the chance of recovery very little. So the physiotherapy and the advice about education of exercise, posture, and stop smoking. That along with that, you probably they put 2 NSAID. I'll put 1 NSAID in the maximum dose. If it doesn't work, you can probably wait for a month, even 6 weeks, and then you probably go into either second NSAID, change the NSAID, or you can go into the next one, that is a TNF alpha 1 inhibitor or similar drug. And that's how you do that. If that is not giving you a TNF alpha inhibitor, whether it could be a infliximab, adalimumab, or there's another one starting with C, I don't remember the name, that is what one of my patients is getting. It really helps. And these are the ones, they have their side effects. I will probably come to that later. They have their side effects.
Excuse me, sir.
Yeah.
Sir, yeah, sure.
Okay. So I'll come to the last slide, and all this are over. Coming to surgery, indications are mainly for deformities and also to improve the function and cosmetic. The commonest surgery is THR, all you know, when the joint is gone. And the commonest surgery for the spine is when there's a kyphosis. The pedicle subtraction osteotomy is the one which probably corrects the kyphosis. And these are all only things you can read in the book. I will not go in details. But remember, osteotomy cervical spine is sometimes essential when the patient's chin is like that on the neck is on the looking down, he can't look up. Then you need elevate the chin from the sternum. For that, you need a cervical cervical osteotomy, and you maybe for treatment for a axial subluxation. These are the 2 diseases which are helpful. So these diseases are only to correct deformity, not for the disease. This is what I want to tell you. And thank you. I don't know. I'm sorry if I took too much time. Thank you very much.
No. Thank you very much, Professor Rajagopalan. This is a large topic, so you've covered a huge amount of it, and I'm sure there should be some questions from all the postgraduates and DNB students who have been listening to it. So I would open it for questions.
So, can you please this one, if you can, for the slideshow, sir, if you can stop that one, yeah.
I'm trying to go back to
Just stop share.
the Zoom.
Okay. No problem, sir.
Yes, sir.
Yeah.
Just go to stop share. You
I don't know
just
where you. I am trying to do that. Okay.
maximize it
yeah.
again.
Yeah,
Maximize
yeah.
it again.
I got it now. Stop
Yeah.
share. Yeah.
Great.
I was searching for that because that was coming in way of my slide. So I
Yeah,
minus it. Now I am able to get it.
Sure. Great.
Sorry.
Yes,
No, that's okay.
no problem. So while we are waiting for questions, so one thing which we have come across in one patient last week while seeing that he has had all the symptoms of ankylosing spondylitis, but in addition to that, he has weight loss of 11 kilograms. So may I know, sir, is it possible that ESR CRP all is raised and he has a fused, both the hips were fused, SI joint tenderness was there. So in that case, tuberculosis and ankylosing can coexist.
It is
In one
called
patient.
Anderson lesion. I
Yeah.
have a patient of Anderson. I had so far 2 cases of Anderson in the last 10 years. Mostly probably we missed it. I was keeping one case to show. Then the time factor I kept quiet. It is
Yeah, I think.
It's a known lesion, Janki, and some patients come with severe increase in pain.
Yes.
Already on treatment, sudden increase in pain, then you have to think of that. And all this about the Anderson lesion, the only treatment is surgery. There's no point treating tuberculosis alone. You have to do that. Not very common, not very uncommon. It was more, I have seen more when I was in John's, but here I have seen only 2 in the last almost 10 years.
Yeah, I think it's quite a well-known entity. So it is possible that the two can coexist.
It's a very painful condition.
Yeah. So there's a question which wants to is asking whether you only see it in younger people and what is the age distribution? 20
to 40 is the common age. I have not seen younger than that, but they can. I have not seen a pediatric age, but they can come later age groups also, because see, really speaking, what is the relevance of age in terms of etiopathogenesis? I do not know. That's something I do not know. But the pediatric age group I have not seen. Probably the highest I have seen is around something 50 odd. But the disease would have been there for a long time. You must understand the progression of disease is unpredictable. In any of the spondyloarthro group, much more unpredictable than rheumatoid. So some of them are so mild, they remain like that. Not all of them go for deformity.
Yeah, so we've actually seen them even in younger patients around 15, 16. And they tend to be even worse. The ones which present early tend to be very fulminating. Whether these are a mix of seronegative spondyloarthropathy or ankylosing, there's always a crossover between the two, which you need to be aware of. And again, they can present to you at any age, but the disease activity seems to slow down after they are 40. Okay? Activity of the disease actually slows down, but not in every case.
So Pushpinder has asked about the protocol for exercise or physiotherapy.
Okay. Before that, actually, I want to just add something to what Dr. John said, because that is very, very relevant. Now, see, when I read for when I had the Anderson lesion, I read for it. One thing, at that time when you look at the etiology, so many pathways, but each one is linked to another one. The age may be important because they're all immune disorders. And as you know, the age may be because of altered immunity. This is what I feel, John. I don't know, it's only my opinion. Yeah. So the younger age, again, the immunity, the difference. And elderly, as you know, immune complexes are all very poor in the come lesser and lesser in the aged people. Coming to the physiotherapy is for maintaining or improving, early stage maintaining, late stage improving of the affected joint. Whichever the affected joint, the first and foremost, no further movement should be lost. So exercises, passive and active, through the full range of movement possible in the joints. Same thing applies to spine, muscle strengthening and breathing exercise. They are the main things.
I think that's important. And one of the things which you need to watch out for and which fortunately seems to happen is when these patients present acutely on bed rest. Okay, that is the worst thing you can do for them because they stiffen up much more when they are put on complete bed rest. Okay, people mistake it for a disc or something and them to go on bed rest. And we've seen a number of these who have come to us very stiff by the end of that treatment. I think you need to mute anyone who's
It's disturbing.
Yeah, I'll
background
just
sound. Yeah, okay.
Dr. John, I have a question for you because because why I'm asking is the patients coming to me, particularly John Pondicherry, they can't afford these biological agents. So
Right.
my experience with that is limited. Whereas you, I know, will have patients coming to that. What is your experience with that? I know all this, but I'm not able to afford.
So most of mine can't either. And I don't think the thing is, I'm still a little, the problem with most of these biologicals is you need to continue taking them. So
Yes.
many people think that they have one or two shots and they're okay, but that's not it. They need to continue. I tend to refer them to the rheumatologist when it comes to biologicals. I don't prescribe them myself.
Okay.
Okay, but so that is one. So I don't know. I don't have the first-hand experience of using biologicals in them because I tend to get my rheumatologist involved if I think they need biologicals. Second thing is that if you give them for a long time, then you have problems with immunosuppression. So that's also something that you need to watch out for. So they get increased risk of infections and things like that. So I think it should be used in some patients, but that patient selection, I personally feel, should be left to the rheumatologist rather than us as orthopedic surgeons trying to decide it. Of course, there are a lot of orthopedic surgeons who are more actively involved in management of inflammatory arthropathy. So if they are happy with it, I don't see anything wrong with it. But personally, I feel that I don't really have the time to spend on the details of some of these drugs. And so I hand it over to the rheumatologist.
So one thing about biologics, sir, is it in early stage cure the disease rather than controlling it?
No. See,
So there's no
that
such
I
thing
can
as a
answer
cure.
you. Why I'm going to answer you because I don't use, but I have knowledge. In the sense, when here in Bangalore, I had no problem because most of them were patients who could. And those days, we didn't have so much like Dr. John said, only rheumatology should prescribe. That was not there. I had even a pediatrics, MD pediatric student, non-sister whom I treated with adalimumab for rheumatoid. They all are going to block the pathway. They can prevent the symptoms. There's no cure. The cure problem is going to be much more. We don't even know how it comes. We can only block the pathways. That way they can prevent the symptom. But the relief I had, there's an ancestor doing post-graduation from using to even take a BP, this thing. She was totally symptom-free, but the toxicity you have to be careful. John, sorry. I think.
Yeah, no, absolutely. I agree with you entirely because the results of some of them are remarkable and they, especially for the inflammatory part of it, obviously once the joints are stiff, they can't do anything, but they are not a cure. They usually need to continue for life really or till they get over that, the active form of the disease for it to be stopped. And a lot of people take it for 1 or 2 or 3 doses and then stop because some of them can afford a few doses, but to continue it for a long time becomes difficult even for the affording patients.
So
we should go on to some of the other questions.
Yeah,
From
my sir, he has asked about what is the reason of nocturnal back pain in second half of the night.
I don't. This is not like right case of tuberculosis. I don't think there's a mechanism by which the thing. I suppose I don't know. Answer is I do not know, but I can think about it. This all since about all these mediators. It is something to do with the what do you call etiology of disease. But I have no answer.
I think it's actually early morning pain and stiffness. So, I mean, once they're at rest, generally the joints stiffen up more and then they have pain. So I think it's more to the bigger, what they'll mainly complain of is when they wake up in the morning, they're having a lot of pain and stiffness rather than specifically in the second half of the night.
Yes, sir. So in medicine book, when I have read about the rheumatoid arthritis, they have said in the dependent part, it is the edema fluid which got collected, and because of that, maybe for the ankylosing, if it is applied or not, I'm not sure.
I think that's...
Sorry, John. Again, I'm interrupting because
No.
rheumatoid, the cause is known. Rheumatoid, the problem is rheumatoid, it is the edema of the synovial membrane which gives the pain. At rest, there is no movement, edema increases. Whereas in the daytime or whenever patient is moving, the edema comes down because of, you see, a joint is a negative vacuum. The movement causes a diffusion and is where the synovial fluid flows up and down. The movement decreases joint pressure. The joint pressure is less than outside. So it is the movement which gives it the daytime. Then night, early morning stiffness, night there is no movement, edema increases. This is proved.
Yeah.
So I have to ask one question.
Who's that?
Sir, Amil sir.
Okay. I think
Sir, what is the drug of choice of sir, ankylosing spondylitis, sir?
We'll come to that. Many questions on the chat box. So when someone's asking why is the alternating back pain in the buttock? Why peripheral joint asymmetric? Profactinib, how long can you give? How long to give? And I say what is the regimen and when to stop DMARDs? So a lot of questions for you.
Alternating back pain is because the gluteal pain, what he is telling is that I think from the sacroiliac involvement. So that this is not bilaterally symmetrical like others. It is random. It is never so. One sacral joint gets involved and the other sacral joint comes. Then by the time it goes to the hip, like that it goes. It is not some, so the alternative pains are like you have the alternating hip pain, alternating gluteal pain is involvement of the sacral joint. That is what is giving the gluteal pain. That is why buttocks, that's what patient says. We are not the one describing the pain. If as a doctor, I would have said, I have pain in sacral joint to you. The patient doesn't know. So the common word they use is buttocks.
Okay, and then about toflactinib and IL-17A, sorry.
Yeah, you have to see the example. If you are going to give the drug, as Dr. John said, moment you stop the drug, the same pathway will come back. As long as the disease is active, you must remember that all these immune modulated these things can pass off. For example, let me say that one particular patient, you have seen him, you may give a NSAID, he may be completely all right. Why the immune mechanism stops, we do not know. Immune modulation is something in which our knowledge is, immune modulation happens because of some other triggering factor. That is why they are thinking that, okay, your HLA-B may be the irritating factor which links a bacteria to the immune complex. So the immune diseases, they can come, they can go whenever they want. There's 10% of these patients become all right without anything, with only symptoms for short time, they become all right automatically. So when disease stops, we do not know. Same thing about rheumatoid. At some stage, it will be burnt out. Then you don't have to give anything. By then, joy should not be spoiled. So like as Dr. John said earlier, you have to continue till the disease is active. Not only this, even psoriatic arthritis. I don't want to push the term, but my brother-in-law in Canada is for taking psoriatic arthritis. You have to continue lifetime. In between, you stop. The patient, the symptoms don't come, then you don't have to.
So they have asked about thalidomide also. Role of thalidomide. I think it is recently introduced in ankylosing. Again, immunomodulator, yes.
thalidomide, after the disaster of the early days, when we were students, when we got thalidomide babies, it came for multiple myeloma. It
Yeah.
acts as an analgesic. That's the way it acts for multiple myeloma. So I have no idea about the role of thalidomide in ankylosing spondylitis. But one of the things about thalidomide is, I don't know, it's still valid now or not. At one stage, the drug would have never come into the market. It should not be used where there is alternative drugs available. That is still there. No, this thing is going to give you approval for the drug. For this particular problem, ankylosing spondylitis, we have alternate choice for relief of pain.
Yeah.
So I don't think it will be applicable in this.
Yeah, that is teratogenic, sir. And again, it is classified as
Terrible.
immuno.
Thalidomide babies were the news in the time when we joined MBBS.
So, what is the reason for cynic corner sign on MRI, probably on the X-ray it is, and should we take it as advanced stage when seen? That
Cynic corner is the early part of the enthesitis. So what happens when there's an initial inflammation. Inflammation produces edema. Edema will see in the MRI a hyperindent spot. And in the vertebral body, one corner of the area, there will be tiny white. So this shows that it is the beginning of enthesitis. So it's a early sign. Provided it will be there after some time, but you take the picture after it has formed a bone formation there, then it's late. But if you pick up the early edema, that's the early sign, and definitely that is the stage where before it radiologically seen and movements will still be good. So it's an early sign.
So, Dr. Shankar has asked about that he has one patient of 55-year-old male follow-up with sacroiliitis with combo spine and sober test is positive. I advised only NSAID and physiotherapy and bathing exercise. Last 2 week patient follow-up and pain reliefs. Can I transfer it to higher center or how to manage?
That's for Dr. John only.
No, I think you have to, for bamboo spine, there's no treatment. Okay, so if he's giving physio and exercises, that's the best thing. Physio, analgesics and exercises, that's the best thing. Okay, so you don't need to, I don't think in the higher center they're going to do much else unless the spine is deformed to the extent that you need to do an osteotomy to correct the spine. Okay, so I think what he's doing is perfectly okay, and he does not need to send it to a higher center unless there's a deformity which is causing problems. Okay, because you can't do much for a spine that's already stiff. When we say bamboo spine, it means there is no chance of movement in that spine. Okay.
Reverse of this question. That is what I was insisting from the beginning. Spot the patient before it goes to bamboo.
Exactly. Yeah.
Don't depend upon psychedelic X-ray, even though that's the gold standard. Don't look at that stage. Look at the early symptoms. Imagine that this could lead. You are only going to go exercise for him. Smoking and exercise. Stop smoking and exercise. So once the bamboo spine is painless, thank God. That's all. Only thing you can tell.
Okay, so now we can come to Dr. Amin's
Yes,
question. What was that?
Yeah, Amin.
Sir, drug of choice, sir. It is NSAID of choice, sir. For it is indomethacin or phenylbutazone, sir.
I will tell you what I use. Which NSAID you use, first of all, is decided by the patient in the same, meaning that should not be contraindicated in him. Already having kidney damage, then there's no question. So like that, already having a gastric problem and this thing. So what I do is, I use either a diclofenac or I use etoricoxib where diclofenac is not advisable. But you should take all precautions of this thing. For example, they say that NSAID-induced nephropathy is probably one of the commonest cause of nephropathy now. So you should look at all those things. But the book only gives us insights. It doesn't give anything more. My choice is diclofenac or etoricoxib, where I cannot give a COX-1.
Thank you, sir.
So,
Sir, any special view for SI joint, sir?
Me?
X-ray, a special X-ray view for SI joint.
Yeah, you have already, when we regularly take, these are all you have to have. See, you need only a good AP view as far as we are concerned, because if you want a special view for secondary joint, that's a oblique view. Here, we don't need that. Here, we are looking for, let me say, early signs. You need only a good X-ray, and should be bilateral, so a good thing. And if you want to see the circular joint, that's an oblique view. But just
So
for
our rheumatologist likes to get
Thank
a
you, sir.
prone view of the SI joints for whatever reason.
yeah, for view
It's,
can.
but I think AP and PA are anyway.
I advise them X-ray pelvis with both the hips, so that you are able to see the hip, able to see
Exactly,
the circular joint.
Yes.
Okay, I think
So- Just one last question. It is they have mentioned, sir, about the smoking, that if smoking has no benefit, but in age, what is the mechanism why smoking is
Yes, no
culprit here?
benefit. Smoking is anyway harmful. That's number one. Number two, the smoking has been well investigated. It is mainly going to reduce the amount of blood supply. That is the main action, vasoconstrictive action of the byproducts. And that is going to cause you much more hypoxia at that area. Whatever your inflammation needs. See, all these are mediated through your blood. Whatever we are going to do, healing drugs, everything. So smoking is going to cause hypoxia, reduced blood supply. So that is why hypoxia, reduced blood supply and hypoxia. That is why smoking is bad. And for everything in which inflammation is there, smoking is definitely bad.
okay. So thanks a lot, Rajagopal. It's
Yes.
been a great this thing. There's amazing interest, as you can see, with a lot of questions coming in. So obviously, people really enjoyed your talk and hopefully have learned a lot from it. So thank you very much, and it's been a pleasure to have you again. We should catch up again sometime.
Definitely, thanks. Thanks a lot, John, for
No, no,
calling
pleasure.
me. I think
No, no.
your visit to Pondicherry also is due.
Overdue, yeah, I know. Well, next year, hopefully, we'll do our 50th.
Yes,
So hopefully we'll come there, but
exactly.
I'm not.
This year was a very good show. About last month or this month, this month only was their 50th year. They were in a
Okay.
very good program. Three
Okay.
of my batchmates had come. Freddy's wife,
Fantastic.
she was their recent
Okay.
batchmate. So
Okay.
we really hope to see you for the next 50th.
No, definitely will, and we'll be in touch. Okay.
Okay, sure.
Great.
Thank you all. Thank you, Janki.
Okay, great.
Thank
Thanks
you
to
very
all the
much, sir.
postgraduates for the questions, and good
Yeah.
night.
Okay. Bye, everybody.
Bye-bye.
Thank you, sir.
Can I log out?
Yeah, sure.
Yes.
Thank you. Thank you. Bye.
Thank you, sir. Yes, sir.
We can discuss it on the phone. Anything else? Okay.
Okay, sir.
Not
Yes,
able
sure.
to leave.